Okay, good afternoon, folks. Welcome to our town hall for McMaster Children's, the Women's and Children's Program, Ron Joyce, the McMaster University Medical Center, all of us together. So thank you so much for joining. As we start today, I want to acknowledge that Hamilton and everywhere that I think anyone on the call is probably sitting, actually sits on the traditional territory of the Mississauga, the Haudenosaunee, and the Anishinaabe, and within the lands protected by the Dish with One Spoon Wampum Agreement. So we should acknowledge that we're privileged to provide care on lands that Indigenous peoples have called home for thousands and thousands of years. And we need to recognize and respect the presence and the stewardship of Indigenous people as keepers of this land. I'm embarrassed by the fact that I have not been doing that during our land acknowledgement during the course of these town halls. The fact that we're on a video call does not in any way, I think, override the responsibility to do that. So that's something I've not been doing, and I'm sorry for that. I'm going to continue to do that going forward, and remind us all of the importance of reconciliation, the obligations and the responsibilities we have. So having said that, again, and it's 3 months. So today is actually our 3-month anniversary since the first time that we did a town hall. So thank you to so many of you that I know, because I can see you, that have been to many of those. And thank you to anyone who is joining for the first time. So again, I don't know if I said that. I'm Bruce Squires. I'm Vice President of Women's and Children's Health, President of the Children's Hospital. So really enjoy doing these town halls. Well, I missed everybody last week because I took a day off, which I hope many of you are doing in the course of this summer. If you're taking a day off this week, hopefully you're not actually on the call right now today, but if you happen to be, or if you are next week, just try and stay cool. It's unbelievably hot and almost dangerous outside, although beautiful. So please be careful. In the spirit of CQY, we've always shared quickly feedback from our previous town halls. And I'm somewhat sheepish to report that it had the highest rating ever, our last town hall. 95% of you said it was super valuable, and that's associated with the fact that Tina Garnett spoke to us for the majority of the call. And I think it was really, really beneficial. So appreciate feedback for folks highlighting that, and we definitely passed that on to Tina. I can say you said you loved her and you loved hearing from her. Another piece of feedback we had was more questions. Get them in, get the question, deal with questions, Bruce. So I'm going to work really hard to do that today. I'm also going to try, because I don't have too many questions written, to say, okay, submit your, go ahead and type them in the chat room. And if we have time, I'm going to move to those that you've typed in. So if you've got a question, please don't hesitate to type it into the chat room, and I'll try and get to it. So let me start with a couple of quick updates, because they actually do also relate to some of the questions and the feedback we got. So first of all, I want to let folks know that, and you may know this, we're now at the point for several days now where there are 0 patients admitted to any Hamilton Health Sciences facilities with COVID positive status. We're at a place in Hamilton where we're somewhere around 4 or 5, averaging 4 or 5 confirmed cases per day. So we've absolutely done an amazing job in flattening the curve as a community. And there's no question that you as healthcare leaders, every single one of you as a healthcare leader have really helped to model that, and are deserve a tremendous amount of credit. This is not a victory lap. It's not done. It's not is not something that's gone away or is going away. So I don't want to in any way be misread to say that I'm bragging, but I do want to acknowledge and credit all of you for that. And really, hopefully, that continues to inspire us to keep doing what we've been doing, because it is making a big difference. And so, you know, just in terms of the Children's Hospital in Mumsy, we've only actually had 3 COVID positive patients over the course of the entire pandemic. And we have to go back to April to the last time that we had any. Looping back real quickly to Tina, a number of the questions were in follow-up to Tina's great presentation. Well, what are we going to do about that? What are we doing about anti-Black, anti-Indigenous racism? What are we doing about equity, diversity, and inclusion? So I'm pleased that Tina's agreed to meet with our leadership team, and this is also happening at HHS as a whole, to develop a strategy to review the great comments we've received, the suggestions, and to put together a plan. So don't have that ready yet, but we'll have updates at coming meetings. It's going to have to be some immediate change and some roadmap. So that's kind of where, at least that's my belief, but we have to listen and to be advised as well by others. Screening, I think folks, hopefully you know that effective today, there are no staff screening booths. So there's, as per the emails you'll have received, you know, some processes that we ask you to follow so as to ensure that you've completed an assessment and you are able to have or obtain a mask on entering any of our facilities. But we've moved away from having staff go through staff screening booths. Just another opportunity again to give such a shout out to all of the screeners, but to acknowledge that such a significant portion of that load was borne by our, and I see, yeah, please, claps going on there, was borne by so many of our colleagues from the Ron Joyce Center in particular, as we had to close that facility. And it was hard, it was challenging, and in some ways there was some significant unfairness to how some of our people were treated, sometimes by patients and families, and sometimes by some of us. And I'm obviously still not happy and concerned about that. But so that was the negative piece. But what these people, what you did, and I should say you have done, made such a difference in the ability of the organizations to stay safe and to provide care. So, you know, I can't say it eloquently enough or well enough. So just again, a huge thank you. The Esplanade for the Mumsy site has opened, I think it was yesterday or today. So again, working to expand the number of, I'll call them respite spaces for food, for rest, for an opportunity to chat in a safe manner during breaks. And so lots of detail on that, but so you know, that's another step to expand those spaces. We are also looking to open the Red Cafeteria as soon as possible and appropriate. Ambulatory care ramp up. The plans for the next stage, we're into stage 2 of ramp up in terms of procedural and surgical care. That the plans for the next stage of the ambulatory ramp up have been submitted by all of our clinics across women's and children's. They're now being rolled up. The ambulatory care task force for HHS, which I co-chair with Dr. Lum, is meeting tomorrow morning to consolidate those, then to ensure that that all of the support services that so many of you provide can work with those additional patient volumes in the context of you know, some COVID restrictions such as physical distancing. They'll do that next, and so by mid next week, late next week, we should be able to announce the timing for that next additional ramp up of on-site activity in ambulatory services. The Ron Joyce Center, reopening those services is certainly a little bit more complicated. So there is a team right now actively working through all of the steps to allow us to resume the provision of some on-site services at Ron Joyce. That will also probably happen in an element of stages in terms of the level of ramp up. So I can't give you the date yet on that, although I would certainly hope and expect to be well on the way some point in August, the very, very latest. So that's my goal. Please understand that that's a goal. We need to work through the plans. Pandemic pay. If you weren't able to join the town hall earlier with Rob McIsaac and other members of the leadership team, you may not have heard that while the province has provided now kind of the release of funds, they haven't provided the details. And so the commitment Rob made is that those funds will flow in mid-August. He also highlighted that he and all of us in the corporation continue to be concerned that despite our recommendations, the province has not authorized the provision of that pay to everyone working in the institution who have provided those services. And so hopefully many of you will have seen the open letters that Rob and other CEOs have placed in local newspapers, the continued advocacy that they've been doing through other media. And then I can assure you that there's continued advocacy behind the scenes to highlight to the province that this is not the approach that we support or recommend. So those are the quick updates. Now let me keep going. 12 minutes, okay. I'm going to refer first to what came in through the survey, just to give you a sense. So I take questions that came from the survey first, then I go to the other questions that have come in. I just addressed the race and discrimination. So here's a pick one topic, and it's a discriminative practice at HHS to require only certain workers, e.g. nurses, to Chronos/punch in while their team members are not required to do this. Can you speak to the purpose of creating two echelons of HHS workers, those who punch in and those who don't? I need more time to kind of look into this, but I do want to share with you my experience at a previous institution, kind of when I worked at CHEO, and where we didn't have an electronic mechanism with workers who did not work the same hours every day. We had a tremendous challenge with errors in pay because of the fact that those hours are unpredictable, and there would be times related to overtime, related to arriving or not arriving at work, or related to the recording, where people weren't getting paid when they should have gotten paid. And so the focus for sure was finding a way where we had the challenge, which is not with the 9 to 5 workers, but with when we have 24/7 variable use or variable time schedules. So that's certainly my understanding why that Chronos has been used primarily for those with variable schedules. However, I'm going to go and get kind of a little bit more detail, talk to HR, to members of our human resources team who work very hard to see if I can get additional for that, and we'll bring that back again. So those are my, to be clear, that's my personal understanding of this situation. What is being done to teach new learners on how to conduct a virtual appointment. Good question. And not everybody's aware of this, but we've produced a significant, we call it a standard operating procedure, but really guidelines and guidance to assist in doing virtual care. That's available on the hub. We'll put it in the link for the next newsletter. What's included in there is a great deal on trying to guide and teach folks to learners and otherwise to adopt virtual care. Learners are only just starting to come back in many cases, and so I know the teams are working on that right now across our services to say, okay, how do we help to support that even more? Okay, so I'm going to keep going. I was wondering why staff are not being told when we've come into contact with positive COVID patient. I understand that we're doing universal precautions to protect ourselves. However, with our extended use masking, we're at greater risk of contracting the virus. Is there any way that there can be at least a general notification to our department when we have positive cases? A lot of us live with immunocompromised family, etc. I'll leave out personal information here, and I would like to get a swab done if I know that I've been in contact with someone who is positive. So ask Connie Gittins, one of our infection prevention and control practitioners, to help us with this. And so Connie has written, it's important to maintain patient confidentiality. The assumption is that any patient can have COVID or any other infectious disease, and therefore you should always do a risk assessment for risk of bodily fluid exposure as part of routine practices to protect yourself and therefore your loved ones. We're universally masking to help prevent the spread of COVID among staff and between staff and patients. Good hand hygiene and not touching the front of your mask is essential to prevent self-contamination. We haven't had cases, so I do want to highlight that, and we are moving to be able to report when we have had cases. So this is now me supplementing. And I do want to encourage you that if you think you've had a breach in terms of your use of safe PPE, then it's important to identify that. So what does the office of the future look like? I'd like to know if remote work will be strongly encouraged. If not, will we need more plexiglass or single-use office spaces? So first answer, will remote work be strongly encouraged? The answer, certainly from my perspective, is yes. And so working on how to work through the logistics, and I think we've got a question here coming up that absolutely acknowledges some of the challenges we still need to work through to make that practical. But I'm absolutely encouraging our leaders to think about and we know we have to in some cases because of the challenges that still exist in terms of physical distancing, in terms of use of facilities. And we know we have to think about, okay, how do we optimize our workforce? I think across society, remote work is one of the learnings, if I can say, maybe it's positive, that's come out of COVID. If not, will we need more plexiglass or single-use office spaces? Well, that's one of the reasons why we're universal masking. There are going to be some circumstances where in a work environment, it's just not possible or practical to always maintain physical distancing. And that's why we have universal masking in place. And our infection prevention practitioners, professionals have been quite clear that when we follow those practices, we are safe. They meet the guidance of the province, I guess, of the country, and certainly in my mind, in many ways, most important of the experts that work here at HHS. So that tells you a little bit of what it's going to look like. I mean, I think it's also going to look like one where we, we may have some more places where we do need to be on site, where we go to do some of the remote work that might not be an office environment. So that addresses a little bit, some of the questions around equipment. We may not be able to be in place right away where every single workspace or even computer is well equipped for virtual care. So we may have to recognize that in some ways you treat it like a little bit like a clinic room, and you have some, for example, suites that are well equipped to do high quality virtual care. And so in my view, that's one of the pieces of the office of the future. Okay, I got to speed up. Myself and several of my colleagues are currently working from home after screening for the last 2.5 months. Happy to do this, excited about learning how we can assist our patients through virtual consults. It's great. So far it's going great, except for one thing. A few of us don't have hospital equipment to do the work and therefore are using our own things from home. And so many of you are doing that, and I have to thank you for doing that as we work this through. For the most part, that's okay, I agree. But for me and another colleague, we're using our personal cell phone plans, not to mention long distance charges. So this means to me somebody that's not able to have Wi-Fi in their home, which could be for all sorts of reasons. So the hospital protocol for working remotely does not cover expenses incurred while working remotely. My manager is trying to assist in this area, but not having much success, and she's unable to provide a timeline for the resolution of the issue. Appreciate if this could be addressed sooner than later, as we're expecting to complete several virtual visits a day, and this adds up to several hours on my personal phone. So I don't know who this came from, so I can't speak directly to the individual, but I do want to encourage folks in that consideration. Let's look at in those specific circumstances whether we need to do something with respect to something other than a phone. Obviously, again, there's a Wi-Fi issue there, which I understand. So I'm going to kind of look to work with the team to solve that. It's going to take a little bit longer to solve it across the board. So I definitely ask folks to please be patient for a bit of time. If your circumstance do allow you with your Wi-Fi, et cetera, to do that from home, that's wonderful. If they truly don't, let's try and work it. So I'm gonna try and work with the team. My question is regarding patients wearing masks. I work in the ultrasound department. We're in very close contact with patients. If a patient refuses to wear a mask, according to hospital policy, we cannot refuse care. This is very frustrating for myself and my colleagues. A patient may pass screening, yet may be asymptomatic, and we sit in a closed room, touching them for sometimes over an hour. I was told by infection control to wear my mask and wash my hands when this occurs. This is done every time, even when patients wear masks. I do not feel supported, nor feel the best interest of the employee is being looked out for. Mask wearing in public is now mandatory in some cities. How is it different in a hospital setting? I understand there are exceptions, but I'm very frustrated at some current events in our department. And so I've asked our infection control folks to reach out directly to the individual with his or her consent, and they have consented to talk about this. And I'm also gonna reach out directly to you as an individual. But I will say here that I've asked the subject matter expert group at HHS to take another look at this. I talked to Kirsten Kroll about this yesterday in terms of providing guidance. That question around the notion of whether as a hospital we would refuse to provide care to an individual when we are doing our own protection through PPE, if that individual was not willing to wear a mask, is a difficult ethical question. At this point, our ethical guidance has been that we don't think we should be refusing necessary care. I'm very hopeful that as parts of the province, the region, and Hamilton, for example, are moving to universal masking being a bylaw in public places, which is not a matter of healthcare and potential life and death. It's a public place, that we're going to further, I guess, increase the sense in the community that that is the right thing to do. So I'm hopeful we're going to continue to reduce the number of cases where this even comes up. I understand and I hear and agree with the sense of this question that maybe we need some more guidance and guidelines to help in managing a situation and supports for the individual as a staff member when they feel in this challenging situation. From an ethical perspective and from guidance at this point, the core here is this organization has not said that we're comfortable denying care to a patient not willing to mask. So more to come on that. The back elevators appear to be 40 years old, peeling, rails falling off, and one closest to the wall goes up to 4 north, then down, then up to 4, then to the 4th floor. So holding button to P floor doesn't work well. Constantly need to be fixed and never fully fixed. If we want staff to use them, we need reliable ones. I absolutely agree. The funding that we get for our aging infrastructure, like so many other institutions in this province, comes from something called the Health Infrastructure Renewal Fund, and we then use that to be able to make these hugely expensive capital repairs. So that elevator is in our 5-year capital plan. This comes from Alan Buxton, the facilities manager here at the McMaster site. It's $300,000 per elevator. So we're hoping that that's on the plan for next year. I can assure you that Alan, like myself and so many others, want that to be renovated. In the meantime, Alan and that team are certainly doing everything that they can to try and maintain and keep up our aging infrastructure. So with you, that's what we're going to keep trying to do. Please do report when you have challenges. Yeah. Hi there. Now that we have more learners present in the building and on the wards, it's getting a bit crowded. Morning accounted 14 souls in close proximity. Revised in the hub that meetings are restricted to 10 people per room, yet on the ward there do not appear to be any restrictions or guidelines in place. Just curious about what is now considered appropriate and safe and how this is going to be monitored. So we did have guidance, again, from the SME group, that in patient care circumstances, in key work circumstances, where we're not able to maintain physical distancing while providing core services, that's why universal masking makes us safe. And so where we're forced to come together in those circumstances, that's how we deal with it. Now, having said that, does that mean that we're not forced to come together? We shouldn't consider other opportunities. So for sure, there's that question, and I think all of our teams are wrestling with that. And I encourage that to look at, okay, when do we need to do this? I would share that I've heard from so many of you that the coming together as a team, for example, around a nursing station to do your huddles and to do your safety briefs is critical to the work you do. And so I think we're doing that balancing in that circumstances. And so wash our hands, practice the safe wearing of masks, and limit that time is really the advice that I would give at this point. Okay. 2 minutes. So I actually got through all the questions, and nobody shared any, so I can actually say for once I got through all of the questions. Folks, really quickly, had an opportunity earlier to share a celebration with respect to staff screening. Want to highlight that to our screeners, to the folks that worked at Ron Joyce. I want to share that again, this team, we pioneered to show that we could move away from requiring staff screening for the entire organization. So you should celebrate yourselves as leaders, as trailblazers. Another great example how I think we've shown that we can really push quality improvement along. All right, 2 minutes. So I'm not going to take too much longer there. I'm going to do again. Nice to say that we have again some donated M&M meats, which also includes vegan meats, gift cards. So to Sue Robertson, one of our early childhood resource specialists in the ASD hub. So congrats, Sue. I don't know if you're on the line. I hope so. To Lisa Neziel in DI, who's an ultrasound tech. So congratulations. And I'm sorry, I probably said your name wrong, Lisa, so I apologize for that. Neziel, I think that's how you say it. And Christy Kowalski. So Christy is in the Pediatric Emerge, one of our one of our RNs. So congratulations, Christy, and thanks very much. 3 o'clock, folks. I think my sense is that you probably want to go back to once every couple weeks rather than every week. You're probably getting tired of hearing from me. So we're going to move to every second week. If you have any concerns with that, let us know. But otherwise, we will see you in this forum again in 2 weeks, and hopefully in many other forums in the meantime. So best wishes to everybody. Stay cool during this, and thank you for all you do.